Now I would like to invite Dr. Geeta to come up here for moderation and to introduce our speakers.
Very good afternoon. After a brainstorming session one and so many questions in session one, I think we all are looking forward for 4 days of these interactive sessions on PNIE. I'm a nutritionist. I'm a PhD nutritionist and hence not a medical doctor. I'm Dr. Geeta Dharmati. It's a pleasure to moderate session two. And the overall questions which were asked in session one was all about what we're going to discuss in session two. Session two is behaviors in obesity. I'm a nutritionist, so we always say "Kalta पण वळत नाही" in Marathi. So the वळलं कसं, how to train your brain, how to work on behavior modification, I think which is a key management strategy in obesity, is what we will be discussing in this session. So it's a pleasure to introduce our first speaker, whom we had privilege of having an inaugural address by him at the same time. I would invite Dr. Rao, T.S.S. Rao, sir, to take us through the session one of his topic, lifestyle and sex focus on obesity. So he's already been introduced by our esteemed Dr. Phadke sir, but just to introduce him further, more detail about him. Sir is a well-known psychiatrist, professor of psychiatry and sexual health specialist in India. And we've heard a lot about him as a president of Indian Psychiatric Society. And while he was speaking inaugural address, I think we got a glimpse of what he's going to talk today. So, sir, I would like to invite you to take this session ahead. Over to you, sir.
Thank you so much for choosing this topic, lifestyle issues and obesity, sex, because in the current day, as I was talking about introductory area, that this has become something important. Everybody has doubts. Everybody has concerns. You endocrinologists may be very comfortable writing the medication, but our job to refer to you that we are convinced and people are convinced, and many of the negative symptomatologies are actually highlighted very significantly in fact, public domain. To be frank with you, though we frequently talk about maybe the desire disorders, ED, and many other such things, one important area what we had missed out once I started realizing, going through, is that obesity specifically as a focused area of discussion. Third, in fact, we are all well aware, the only point, suggestion for the organizers, see, if we don't have laptop here, means you repeatedly have to look at, no. Ladies means you will enjoy the backside, but man really to... huh? It is something painful actually then. Because this eye contact what we need to have with the audience gets lost. I think one of the suggestions, please keep the laptop here. That way, in fact, we know what actually is next coming. Why this laptop is also necessary? It's just like sex. You have to focus. You don't focus means you will get lost totally in this thing. And majority of the problems, because I failed, it sets in a vicious circle. We get distracted by multiple things. And many men only realize the value of thinking because any lady would be thinking much more than man actually. In fact, all worst possible things, if somebody has to think, somebody is thinking, it is actually ladies because we have too many responsibilities. And this is one of the reasons worldwide, sexual problems are much more commonly reported in women than actually in men. 1/3 of the men, half of the female population, sexual problems are reportedly common. So coming to the topic, lifestyle issues are extremely important. One example I'll give you. If somebody does 20 minutes of moderate exercise every day, the DHEA level, dihydroxyethylamine, increases by about 2 to 3 times at the end of third to fourth week. But of course, there is a corollary is that if somebody, a Pahilwan, in fact, there is a lady who married a Pahilwan thinking that she would be very happy. In fact, she was very disappointed. The reason is, if you do very vigorous exercise, totally concentrate on exercise, the DHA level comes down by half at the end of 4th week. So there are a lot of issues. When you are trying to talk about lifestyle, this is one of the extremely important area, and having a scientific basis, understanding this particular aspect is extremely important. One of the things extremely commonly mentioned is that every patient who come across in your clinic, there are also sexual problem cases. In fact, I go with an idea that every person you meet on this earth, they are sexual problem cases. Yesterday, today, tomorrow. You got the point? We have not developed problems so far. We are lucky. But we are there in the queue. The idea here is actually, if you just make a small inquiry, the things change so drastically. There was a study done, say for example, in sexual medicine clinic, approximately about 10% of the people will come and talk about sexual problems. What I'm talking is about sexual medicine clinic. In maybe take a medicine clinic or maybe something, a general clinics, even this particular number will not be there. You add only one question actually to them, that do you have any sexual concerns to talk about? The number of people who come forward increases by about 50%. This is a hard data available, and Mayo Clinic has come out with one of the scale. It talks about, in fact, this whole initiative has to come from doctors. We have to be proactive. We have to take the lead. Many patients won't know what to talk, whom to talk, whether to talk. No, you got the point? Many of these type of confusions are existing. And Mayo Clinic talks about just 4 questions. There are 2 things. One is actually, I am not focusing there and talking something different. Maybe a little bit of confusion may be there. But sex is, you can start somewhere, you end somewhere. So it doesn't really matter what you are trying to talk about. So Mayo Clinic talks about 4 questions. Do you have any sexual concerns to talk about? In fact, we are breaking the ice. Any particular specific area would like to discuss? That means you are bringing the focus to some particular area. Of course, there they have with men, women, and with both. That is actually for the Western population. And the 4th component is actually, it talks about in the last 6 months, do you have any? Oh, turn. I don't want to show my back. That is the whole problem here. Men love to show the front. You got the point? Back is something which we find it very difficult. Very few people appreciate that. So, whether in the last 6 months do you have any sexual concerns to talk about? See, just 4 questions can make wonderful change. As I told you, in fact, you are really lucky if you have somebody, a person actually who is interested in this particular field nearby, who can actually correlate, cooperate, and in fact work together. But even otherwise also, one of the most important points you have to talk about is actually whether sex it has any influence or not. See, we treat with so many drugs, antidepressants, antipsychotics. I talk about antihypertensives. You talk about any drug for that matter. Each and every drug has some problem or other. See, somebody was talking about antidepressants. See, those drugs which acts on 5-HT1A mechanism, they are safe drugs, and even maybe about 5, 10, 20% of the problems what actually they might have reported. But all other things, the 5-HT, B, C, or 2, any one of these type of receptor mechanism acting drug, they can create problem. And many people, they don't take medicines in our side, not because of anything, they are scared of kidney problem. That is one of the most commonly used terminology. The other one is produces sexual problem. So when you are writing some medications for even management of diabetes or maybe obesity or things like that, people will have this high concern related to whether this will affect our life in some particular fashion. When I was trying to read, there is so much advantages are there. Very fact that weight can come down itself is actually can become something really good. I had one case very recently. This is a bank manager, retired, and not getting interest with sexual activity with the wife. And his concern was, She's not that much obese or anything like that, but all said and done, her arms are a little bigger than usual. In fact, he told her, somehow I don't get aroused because this increased size and maybe the shape. This is usually, in fact, could be one of the simple problems for having the sexual problems. But she reacted very badly. He told how you are getting aroused. He told one should be like Aishwarya Rai. So her comment was, you are loving Aishwarya Rai, not me like that, so don't come near me like that. Last 1 year, she has not come to me. What I am trying to tell you is each case may be a little complicated. You have to go into the details and try to look into what precisely is happening. And among all the things, here the only issue that came up problem between these two is little increasing girth and a little bit of increase in weight, which created this type of difficulty. So many men, almost half of the population, might be actually presenting with this particular problem. So who presents? None of the patients will come and present you with sexual difficulties. Very rare. Even those cases which have been specifically referred, you leave out those things. All other people, they come and tell you about so many other different things. It may be the weight gain to fatigue to the sleep disturbance to lot many other things. And what he actually carries is actually some sexual problem, some sexual issues, or some anxieties related to sexual issues, which we need to definitely look into. So what we are trying to talk about is consider the screening test. If you just ask one extra question, do you have any sexual concerns to talk about? Why this conversation? Sex is one of the extremely important. I don't think there is anybody who doesn't get anxious about this particular area. However comfortable. Later we are going to talk about sexual wellness concept. Sexual wellness concept talks about not that you have a problem, but how much it can be improved. There is almost always scope for changes to be brought about. So we try to cover briefly about some of these areas. This is not my usual topic of presentation many times. In fact, obesity and sex, this is the first time I am trying to talk about. But all said and done, there are plenty of aspects are there actually. And we are all well aware WHO definition of health. But there is another definition called sexual health related issues where the focus is on one way or other, our health is related to sexuality. Extremely important to be kept in mind. And it says it is just not merely absence of the disease, but how best it can be improved. That means again, all the domains what we are talking about, 4. Additional one, sexual health as one of the important component is actually one of the most important aspect. So many of these things talk about many of the social and other problems we are actually dealing with. Say early pregnancy, teen pregnancies, STIs, and many other things are also areas of the focus. But in general, sexual problems themselves actually has been taken as a little more seriously the issue. Obesity, I won't talk much, except that as a formality, few things are there. What we talk about the Western model and few of the things, in fact, I was trying to look at the Indian and Asian population in general, whatever standards, what they have put up actually is not necessarily applicable to us. We are much more sensitive, even a little bit of BMI changes, much lower, even say 23. In fact, if you talk about 25 in Western population, that means BMI standard and all may not be applicable from what is available as a Western standard to what we basically call Asian or the Indian standard. Same story was when you are trying to talk about antidepressants, antipsychotics, what are actually mentioned in the textbook and what we actually, in fact, our patients respond, there is a wide type of difference. Even among the same group of people, in the same family, 2 people respond quite differently. Again, all of these type of things have been explained by various methods, and now we have that biochemical to lot many other areas which actually we talk about. One important thing people have found in our country and everywhere, in fact, one of the most common problem Indian men in general is this abdominal fat. Even though we are not overweight, somehow we are actually prone for this. And when we are trying to talk about abdominal fat, this is not an inert fat which is actually sitting there. In fact, people talk about this being actually one of the most common area where so many what we call inflammatory and lot many other such actually molecules are produced, and it is actually having effect on. So generalized obesity to abdominal obesity, if you try to look at, our population is extremely known for this particular aspect, the changes that actually we are seeing. 1 in 4 Indian adults are now overweight or obese by BMI 25. And if you try to look at 23 as the parameter, this absolute number actually increases drastically. I'll just skip this particular area because you will be talking about all these things. And the important criterion is actually this fat in certain areas has been recognized as in fact, extremely important for the range of anti-inflammatory molecules actually it will release and it actually creates. Apply the Asian Indian cutoff and India's true burden rises far above the headline. India's lower absolute rate marks the earlier onset of metabolic syndrome. And why we should keep it in mind? In fact, these epidemiological studies, there is a whole data available, including what we have done in house-to-house survey, men and particularly women. In fact, 3 or 4 MDCs of the students was related to the general population in related issues. When we did the initial, what we call sildenafil citrate trial, 22% of the people who had presented for ED, first time we could recognize it is actually diabetes. What it actually means is, this may be one of the first indicator of a lot of vascular and other related changes. Actually, this is actually coming into the function. So how obesity dismantles sexual function, this is a very vast area. A lot of work has happened in this. It acts by vascular, hormonal, metabolic, psychological. Each of these areas are, in fact, one can elaborate in great detail. What actually we are trying to talk about is this whole range of inflammatory, what we call markers, excessively, in fact, released in these individuals, and this has been attributed to what we basically call adipose tissue. If we try to look at penile artery and coronary artery, in fact, penile artery is much smaller than even the coronary artery. This is one of the reasons why at least 3 to 5 years earlier to coronary symptomatology, the penile shock or whatever you call it, in fact, this is supposed to come up. So one of the earliest indication, if somebody presenting particularly middle age or earlier age with some of the changes, one should become alert. He need to be investigated properly. This is one of the important area. Adipose converts what we basically call testosterone to, in fact, estrogen. Aromatization is one of the major mechanism. Insulin resistance, inflammatory cytokines. All these 3 things are extremely important component. Ultimately, it actually acts on this. So going a little forward, there are many ways. Again, you are experts in this area. I will not go into the details because they will come to the last point, which is actually extreme broad. Erectile dysfunction is common and metabolically driven. And among all the things, see, time was there when we used to talk about erectile problem is actually mind problem. You think about it, you get erection. There is something wrong there, you don't get erection. 95% of the problems are actually mind-related problem was actually the thing we used to talk about 3 to 4 decades ago. Then, in fact, the data started coming from diabetic clinic, hypertension-related problems, and lot many other things. 90 to 95% of the problems, in fact, this is one of the common cause which was actually reported. Now we are very clear-cut. All the cases are what we call mixed variety. We need to actually look into almost all parameters and come to the conclusion. I had recently one of these Pandit, very well read person, and even medically speaking, in fact, a lot of enthusiasm to read and understand. Somewhere I went to clinic and they told you are pre-diabetic. You are likely to develop, you must do something and all. Following which he was not able to perform at all of that. The reason is, he has read everywhere that, in fact, hypertension, diabetes, and other related problems actually produce erectile dysfunction. So, it looks like it may be diabetics related and all that, but the individual, actually what is present is actually psychological. What it means is, we need to definitely spend a little bit of time to understand. That means history is actually one of the extremely important. So, any person with obesity as one of the important parameters, if you take, that means erectile dysfunction, hypogonadism. In fact, this is actually mainly attributed to SHBG and so many other related things actually which are created, whether we are talking about a whole range of rheumatoid arthritis disorders, autoimmune disorders, and lot many other conditions. Any metabolic syndrome persisting for a long time, and particularly along with obesity, the chances of hypogonadism increases drastically. And metabolic syndrome associated. That means these are the three things actually we definitely need to taken care of. This is, say, for example, if somebody is having erectile dysfunction, when we used to talk about so many things, we used to mention there is one idea, even obesity also should be kept in mind. But now, whether this itself is one of the most important area, whether we need to definitely look into. Presence of obesity, the sexual problems multiply in a very significant way. And this is applicable to both males and females. And as actually individual aging, this is likely to produce much more problems. What is the sexual medicine journals report? Dose response, it is not just a threshold, but it definitely carries the weight. Waist beats weight. This abdominal girth as one of the important parameters. International Index of Erectile Function can actually give us actually how to go about. And all of these things carry this what we call as the vascular signature. Ultimately, vascular problem actually has been documented as one of the most important area. Vascular, hormonal, metabolic, neurogenic is actually a mixture of all these things which are actually creating difficulty. In men and women, in fact, it produces problems. We are all well aware of this particular fact. And when you are trying to talk about men, one of the most important area which gets affected is actually the desire. See, if you try to look at earlier literature, we should talk about premature ejaculation as the commonest, ED as the second common, desire disorders are the least common. But the Levin study, extensively reviewed, and in fact, it has been documented that the desire problem is one of the most common problem when we are trying to talk about sexual problems. And this rule applies both for men and women. And this rule becomes very significant if we are trying to talk about an individual who is about 40, 50, 60, 70. This becomes one of the extremely important area of concern. So, both in men and women, this can produce problem. Once somebody has a desire problem, it invariably affects arousal problem also. Very classically described in case of men, because we can very clearly delineate. Women, very difficult to understand women. I think before I leave this place, I may get beaten up by you ladies and all that, but let me tell you, this is the problem even scientists had. See, in case of male classification of sexual disorders, we talk about hypoactive desire. In fact, we talk about erectile dysfunction, arousal disorders. We talk about ejaculation problems. You got the point. But women, DSM-5 classification, if you try to look at where the desire starts, where the arousal happens, it is not possible to make out. So ultimately, they scratched their head and all that, they gave up. Ultimately, they brought all the things together and they made one broad heading called interest and arousal disorders. Now, you got the point? This is one of the major common difficulty because as far as the female sexuality is concerned, it is just very difficult to make out where, when, and what precisely happens. So, in fact, tomorrow I am talking about orgasmic difficulties in case of the women. This is one of the other area. Majority of the times we have spoken about this interest arousal disorders. But this orgasmic area, this is one of the things which has been totally missed out. If somebody has the questions, definitely I would be like to talk about those things. So, there are plenty of cases, varieties actually we can bring in. What we basically call an executive, a housewife, or this thing. If you go into a little more into the detail, when they have some sexual problem, there are a whole range of other things are actually associated. Or they have come for something else, and you see that the sexual problem is actually one of the most common area which is actually likely to be there. So Indian numbers are not small. In fact, whole data is available now. Each of these metabolic syndromes, what is the extent of difficulty, obesity and female sexual dysfunction, one of the extremely common reported problem. Dr. Vaishali Madam was telling a few minutes ago, obesity or something like that when women come. In fact, this is the area, if you just go into a little more into the detail, they'll come forward. The only issue is whether you give a little bit of privacy or other related things. If they become confident, if you are able to establish some rapport, in fact, they would be the first people to actually come forward and talk about it. And we deal with many men and few women in our clinic. And many of the men who have come for clinic, they are all because of the, again, women who tell them that go and get it checked. One of the most other common problem is actually somehow wives are very tolerant and they are actually taking care of their husbands very nicely. It is these girlfriends or others actually who create problems. I am not able to perform. This is one of the things for which actually he comes for treatment. And the cardiologist, any cardiologist in this group? See, one of the very common advice is actually that you have developed this particular coronary event, no sex. No, you got the point? And there are some cardiologists who go a little extra. You can have sex with your wife, not with your girlfriend. Because with the girlfriend means it is actually very strenuous and something significant. With wife means chalta hai. Somehow we can manage it. This particular, some of these impressions, what actually many people carry. In case of man and woman, there is hardly much difference. In case of man, arousal, we talk about erections, but in case of women, it is actually swelling and lubrication. But this is one of the area which gets very significantly affected. Sex is one, lose or use. In fact, you use it, in fact, it stays. You don't use it means it actually keeps disappearing. This is one of the extremely commonly this thing. And along with that, we have very well aware of PCOS and other related problems, what you talk very regularly. So, when we are trying to talk about sexual problems, it is a mind problem. Not because it is purely mind related, but ultimately, whether we are talking about other associated problems, comorbidities and all of that, but again, brain is actually one of the most important organ we talk about as the, in fact, it is the biggest sex organ according to the whole literature. Because so many things are happening and how we actually maintain it is one of the most important. Mood is one of the most important criterion which determines ultimately everything. So one has to spend little time, and if you have a clinic where associated consultants are available, this is one of the best thing what one can talk about. So message, this is one of the early indicator of certain complications that may be coming up. And our job is to see that, in fact, make them explain, understand that this is actually common. Many men come and tell us that I was so good and many of these type of things, but now the whole lot of problems have come. See, let me tell you, I am now 73 years old. I was like Salman Khan, like a tiger. Now you got the point? But now you come to our house, I look like Ekta tiger. Now you got the point? However, I may try to actually manage. No, you got the point? This is the type of difficulties we are likely to encounter in the coming days, and one of the most important things is actually normalize. Felt but never said, so encourage people to talk about it. Why patients don't tell you? For many of the reasons, they don't know that it is actually a problem, and the shame and guilt and other related things, and many doctors, they don't have that amount of time. See, in Mysore, we have another psychiatrist. If anybody starts talking about something and more than 5 minutes means, there is one doctor there, Rao, you please go and talk to him like that. No, you got the point? This is the problem with the psychiatrist means you can understand you are all in a very busy clinic and all of that. Hardly there is time available and you don't spend that amount of time. Only thing is we have to spend some time. There is no other alternative. I was there in one of these ad board programs of many specialists. In fact, like you, a lot of specialists were there and we were myself and other one psychiatrist, only 2 psychiatrists were there. They were trying to calculate everything in terms of time. Monetization of time. Our whole job is actually to see that there is endothelial dysfunction or something like that. Say you talk about obesity, diabetes, hypertension, and you try to treat this particular problem. This is the same story. When sildenafil citrate was introduced, all men felt all their problems are solved. All women felt their problems are solved. 2 years later, almost a study of about 2,000 plus couples, it came out with the idea that hardly anything has changed. The reason was erection alone solves the sexual problem means it is not going to work in that particular fashion. There are a lot of other things are there. I'll come 1 or 2 minutes later. But the problem is not asking means actually, in fact, you are increasing his anxiety, his mood is affected and he is not regular with the medication. A lot of such things and other related problems. Establishing endothelial dysfunction is one of the important aspects. There is no question on that particular point. But there are a lot of other things also we need to keep it in mind. Because I was told only 20 minutes. Otherwise, see, sexologists are something like we know how to start, but we don't know how to end. You got the point? This is the main problem. But you told me 20 minutes, you complete that way. So let me just be there. Spending some time talking to them is extremely important. There are a lot of areas which actually, say many people are living with diabetes, whether you have. So you ask directly question, in fact, they will hesitate. Make it a statement and answer. In fact, Socrates method and a lot many other things in fact people talk about. Start from something neutral and then come to this thing. In fact, this is what called as filter mechanism that ultimately you will end up with some area of your concern and you bring him to that particular point. So, open questioning, acting permission, timeline and severity, organic versus psychogenic causes, impact in relationship, consent and action. So, there are multiple steps how actually one can go about. These are a few things which actually people have documented. If somebody asks me what is the ideal life, there is nothing like ideal life. Ultimately, we have to function to the optimum extent possible for what is given to us, and it all context dependent. This is one of the very beautiful terminology Padke was mentioning. So, extremely important. Appropriate integration of physical, mental, social, spiritual, sexual, environmental is actually one of the things. And currently, in vogue is actually what we talk about is the wellness concept. All of us age. Somewhere, in fact, maybe 25 to maybe 50, 60, in fact, very appropriate age and all we used to talk about. But if we try to look at our own life, a lot of good things and a lot of important things, a lot of productive work is happening after 60 plus. This concept has been agreed by many of the Western people, but we never actually bothered about these things. In fact, in Kerala, the retirement age for the government doctors and in fact, many of the CEOs and other is actually 58 years. Can you imagine? See, as far as the maturity is concerned, we are all well aware. There are very clear-cut delineating terminologies available as far as the women are concerned. Menarche, some point. In fact, this is one of the reasons why marriage age is this, that, and all of that. But as far as the men are concerned, men mature itself is actually one of the questions. You got the point? Ultimately, nothing else could be done. They put that 25 years as the age. You got the point? Because purely. And you are all well aware, marriage means what? One lady transferring her baby to another lady. You got the point? So, this is the way it works. I am yet to come across a lady who is married and happy. No, you got the point? The whole difficulty is girlfriends are so good. But wife, once she becomes, the whole problem starts because plenty of explanations and reasons one can actually give. Around 60, 70, 80, in fact, people start performing well. And when we are trying to talk about sexuality, this one I can talk for hours together as far as the female sexuality is concerned. See, men also, there is a decrement for various reasons. You talk about metabolic syndrome, you talk about age, you talk about smoking, you talk about alcohol, and lot many other things. It is almost always a downhill course. And very clearly it can be documented also. As far as the women are concerned, see, all through female sexuality is inhibitory female sex. There is almost always a danger, almost always inhibition, almost always, whether you're talking about animals, you are talking about, see, for example, I can give you one example of two small puppies. My mother gave a little bit of milk. How much minutes are there? Another 1 minute, is it? 2 minutes, huh? Okay. These two puppies, when they grew up, this male fellow, you have closed the gate means also you jump the compound wall and meets towards his girlfriends and comes back. No, you got it. This female dog, you have kept the door open means also still is there inside. So primarily inhibitory. Somewhere around 40, 50s, what happens? All these inhibitory female hormones are reduced. And women become, not yet 40, not only men, women also. Unfortunately, all the data what is documented talks about still problems being high in case of females, not because of anything, but because of the social, psychological, and such other reasons rather than biology. One should almost always look into. And married for 10 years, 20 years, 30 years, now they are talking about divorce and other related things, not because of anything, but there is a significant mismatch that happens at this particular age. So to overcome this, if you try to look at ICD-10, ICD-11, or DSM-5, DSM-4 or DSM-5, we talk about the reason for which the individual is seeking help. It doesn't convey anything. Why you people are extremely important for evaluation is actually this WPS system of classification. This WPS system talks about two components. Of course, second component will not go into too many details. The first component, again, multi-axial clinical disorders. The reason for which he actually is seeking help. But there is another component called as other mental and general medical disorders. Either depression or medical disorders or the treatment related associated things are extremely important to be kept in mind, and please evaluate. This is one of the important message. Disabilities. What is the extent of problem it is actually producing in any one of these areas? There is actually a scale available, none to massive. And other area is actually, in fact, family, education, economic, cultural, environmental, personal. Each of these areas need to definitely look into. And sex is one of the most important quality of life related issues. So, message what I am trying to convey, sex is one of the important aspect in whatever you are maybe trying to do. Negativity is there. In fact, stress is actually part and parcel of the problem. See, how to make it very simple. Say, depression is for something which has gone back. Stress is something what you are going through at this particular junction. Anxiety is anticipatory. What is going to happen next? You got the point? It is very easy to. And let me tell you, in fact, to understand, to make you understand this thing, when you take it as a joke, so how to understand anxiety, depression, this, that, and all that, many people talk about is that. Stress is when your wife is pregnant. You got the point? So she is not available for you for some time, you feel little nervous. Anxiety when your girlfriend is pregnant. No, you got it? This produces little more than what is actually necessary. Panic when both of them are pregnant. You got it? Little more. Depression or a tragedy when you have not done anything but both are pregnant. No, you got it? Very easy to understand. Psychiatry, in fact, you have to take some classes and all that, in fact, explain all those things. So stress is one of the extremely common problem, and this is one of the things which is actually leading to. And what is actually missing, what we talk about is actually this emotional satisfaction. For that, we have to spend little time. No marriage is investment free. You have to invest certain things. This is actually we talk about. So just to mention, junk food. In fact, now digital this thing, spending a lot of time sitting somewhere and not working. In fact, this is as much good, as bad as smoking. People talk about it. Sleep not being attended properly, not doing exercise, and a whole lot of these things. So lifestyle issues are extremely important in individual's life, and one actually definitely look into. Just 1 minute only I'll take. Clinical practice guidelines, if somebody is interested, our Indian Psychiatric Society. And from first and second, we are talking about CPG on range of sexual disorders in psychiatric disorders to, in fact, medical and other disorders. Dr. Parekh is also part of it. IPS textbook of sexual medicine is there. And we publish this Journal of Psychosexuals, open access and the in fact, most popular journal. Most welcome for you to participate. Thank you very, very much. This is one of the new book which is coming up from our side. And thank you so much for this wonderful opportunity what you have provided.
So attention grabbing you and your topic. What I can say in one word, you are magician. In whole life, I attended thousands of presentations. I couldn't give 100% time to any presentation. This is the first presentation when I invested all my time to you and your topic, the way you presented. Excellent, sir. Yeah.
See, giving 20 minutes talk to a sexologist is equal to experiencing premature ejaculation. Neither I am happy nor you are happy. No, you got the point?
So we will plan a conference on sexual medicine next time, I think. And very
have to learn from you how to present so nice.
Exactly. Thank you, sir. Thank you, sir. I think we will have you again for panel discussions and there'll be a lot of questions on it. So, very truly said that 20 minutes is not enough for this. But because of lack of time, we move on to the second topic for this session, depression, anxiety and obesity link. And I would like to invite Dr. Vani to talk about this. Dr. Vani is associated with SYNAPSE, I think from the conception, and she knows the concept of PNI so well that she connects with all the facets of what we are discussing about neurology, immunology, nutrition, till nutrition. I think she knows it well. So her slide says it all. She's a senior consultant psychiatrist at Amar, Bandra, Mumbai. Over to you, Dr. Vani.
Okay, I don't know what definition of anxiety would be in women, but I can tell you that I am feeling it now because I have very big shoes to fill. So after that enthusiastic lecture, I have to tell you about something that's very core psychiatry. I don't have a presentation. But my topic is anxiety and depression with respect to obesity. I don't know how many of you are psychiatrists here. Can I? Okay. So, not many psychiatrists. And so, I'll first begin because whenever I talk about anxiety or depression, whether it is with patients or with colleagues who are non psychiatrists, the essential question we ask is what actually is depression and what actually is anxiety? Because if we see that anxiety and depression, two things are happening. One is that it's become a very normal part of everybody's conversation. Like somebody goes and doesn't get a movie ticket, they feel depressed. And before going there, they feel anxious that whether they'll get a movie ticket or not. So, is that the kind of anxiety and depression we are talking about? Second is there's a huge amount of that lot of things in the media which says that okay, this is clinical anxiety, clinical depression. Means does it require a formal treatment? Does it not require a formal treatment? And so a little bit of clarity on what exactly we are talking about when we talk about anxiety and depression. So we psychiatrists, when we talk about depression, it's clearly defined as a state of persistent state of sadness of mood. So it's not something that you feel very briefly, that you feel in response to something happening in your life. It is something that is like a dark cloud on your life. And no matter what you try to do, so usually when your mood is low, you're not feeling good, you try to distract yourself, isn't it? So you try to go to a movie, you try to talk to a friend. So these normal methods of distraction, they don't give any kind of lasting relief. The depressed mood comes back. That kind of depression, and it's also a common misunderstanding that depression is only something to do with your mind. Actually, depression is a systemic problem. It affects your body as much as your mind. Therefore, when a person is depressed, it is more likely that their sleep is disturbed. Either they sleep too much or they sleep too less, or whatever sleep is there, that is disturbed. The appetite changes. There may be increased appetite, decreased appetite, inability to enjoy food, the digestion gets spoiled, energy levels are low, there is vulnerability to multiple minor and major illnesses. So there is now a study which lasted for almost 25 years, and it's covered almost 7 lakh patients in China, and they have shown that cardiometabolic disorders are preceded by depression and anxiety by almost 10 to 15 years. So there's untreated depression and anxiety can lead to organ dysfunction like cardiovascular disease. So depression is not something to be taken as a passing phase, mood or light thing, that will just go away. It's a real medical disorder which involves dysfunction of the entire body system. And the key symptom or the key experience of that disorder is persistent sadness of mood. Now, what about anxiety? Now, anxiety occurs, again, depression is a part of normal experience. We do feel sad normally also. But what differentiates it from a normal human experience is that the quality of depression. The person who is suffering from a clinical depression experiences pain due to their emotions. So when something bad happens in our life and we respond to that with sadness of mood, it gives us some kind of response and some kind of satisfaction, even in that sadness of mood. But a lot of depressed mood appears unjustified, imposed. A lot of patients will come and tell you, I don't know why I'm feeling like this. It feels imposed and it feels extremely painful to bear. That is there's a qualitative difference in the depression. Now, similarly, anxiety is, in short, a persistent inability to relax. So the person is constantly feeling tense. Again, it has both physical and psychological components. The physical component would be something like heaviness of the chest, palpitations, feeling dizzy frequently, sense of not being able to take a full breath. Many patients go to respiratory physicians saying there's something wrong with our respiration. We have shortness of breath. Even though we are sitting in one place, there's feeling of shortness of breath. There may be tendency to feel dizzy sometimes, startled easily. Somebody talks loudly, or there is a very active movie scene going on. The person cannot bear it. They become overwhelmed quickly. That is the physical experience of anxiety. And the psychological experience may be a different kind of thoughts. There's excessive worrying, this will happen, that will happen, I did this wrong. So there's constant worrying about different themes, which commonly nowadays we call as overthinking. And anxiety can be in a particular place, such as there may be fear of darkness, fear of insects, or there may be anxiety that is present with you for 24 hours. So is it clear that what we are talking about, when these two features are present, these are actual clinical mental health disorders? Other forms of anxiety are not so pathological. I mean, if you are not anxious about your exam, it is expected that you will not study for your exam. That's the commonest example that people give. And so anxiety and depression have survival value, but when they become morbid, that is the time that the body suffers problems. Now with obesity, when anxiety and obesity, we try to, anxiety, depression on one side and obesity, there's a bi-directional relationship. Both anxiety and depression can cause or enhance obesity, whereas obesity also can cause anxiety and depression in the patient. Now, how is this relation to be understood? This can be understood in terms of shared biology. As Sir and several earlier presentations mentioned, that obesity causes an inflammatory state. There's release of lot of inflammatory, pro-inflammatory hormones by the adipose tissue itself, and depression mainly and also anxiety is also an inflammatory state. So it some of the people with depression, they come and tell us they also complain of fevers, but when you take the temperature, there is no fever. So the subjective sensation of depression and anxiety is also of malaise, and that malaise is one of the symptoms. Again, it's a subjective feeling of the inflammatory state, and that is coming from the pro-inflammatory substances that are released during the of the patient with obesity. The second shared vulnerability is dysfunction of the HPA axis. The hypothalamic centers, they control both the hunger and the satiety centers. And in depression, there is a definite dysfunction of this HPA axis through the cortisol and all these things. And that is why they can either lead, in many patients, also with depression, anxiety, there is not only one type of depression or one type of anxiety, there are some atypical forms of depression. And in atypical forms of depression, the person has more appetite. The appetite is increased, and therefore there is lot of weight gain happening. Third is, as Madam said, a lot of medications which we use. They are known to cause, but here I think I am focusing more on the clinical aspect. Here a little nuance is important. One is when the patient who has a combination, who has depression, anxiety, and then has been put on a treatment for depression, anxiety, comes to you saying that I have gained weight. We have to understand how this weight gain has happened. Earlier, we used to use a group of medications called as tricyclic antidepressants and tetracyclic antidepressants. Weight gain was a very significant problem with these. For one is, of course, they increase the appetite, but the second mechanism was also because of dryness of mouth. So typically when we get dry mouth, we don't go and drink water all the time. The tendency is to have more of tea, coffee, beverages, cold drinks. That again, through the osmolar pathway, it again increases the thirst, and again there is this thing. And a lot of people are unable to differentiate between hunger and thirst. So in response to thirst, a lot of people would also consume extra calories. And a little by little, that causes weight gain. That is one of the mechanisms. Nowadays, luckily, we have a very broad spectrum of medications, and many of these medications do not cause weight gain. SSRI is one of the examples. SNRI is another example. So TCAs and those things are practically, we are not using it now. We are using more of SSRIs and SNRIs. And in the context of these drugs, which inherently don't increase hunger or don't have any such side effects which I described, still there could be weight gain. Now that is the point where we have to see how this weight gain has happened, because it is entirely preventable by education. What happens is, when a person is depressed or anxious, their whole social and personal life is changed. They don't enjoy anything, they don't go out much. But as they emerge from their disorder, they begin to enjoy their life. So how do we enjoy our life? The most common way to enjoy life is to eat. When we socialize also, I mean, how many times do you meet somebody in a garden or in a forest? You always meet in a coffee shop, isn't it? And what do you do in a coffee shop? You eat. What do you eat? Pastry. So all our rituals are around consumption, and we have to educate the patient that this is the point. About 4 to 6 weeks after starting the antidepressant treatment, patient starts feeling better. We have to tell them that this is where you have to be careful. If you delay this point of education to 2 months, what happens is that a patient gets habituated. Now they are used to having pastry. Now they are used to meeting in the coffee shop, and a new habit cannot be started. So before the maladaptive habit starts, you will have to educate the patient about healthy eating, healthy socializing habits. Second thing also about alcohol. Alcohol gives a lot of empty calories. And nowadays also there is a trend towards using a lot of alcohol during socialization. So that is also a point of education. When we do this type of intervention, at least in my clinical practice, I have found that it's an extremely powerful preventer of obesity. The other motivator is about 4 to 6 weeks after starting any antidepressant or anti-anxiety medication, we also educate the patients that physical exercise is a very strong antidepressant and anti-anxiety. In fact, if you look at the NICE guidelines and the NHS protocols, they have said that mild and moderate depression, if the patient is motivated enough, don't give any medication. Just prescribe vigorous physical activity as per the WHO standards. This is something you can give to the patients. Because like Sir said, patients don't like antidepressants. Because if you Google the side effects of antidepressant, the first thing that comes is sexual dysfunction. So use that as a motivator, that we want to keep the antidepressant as short as possible, but then you have to develop some antidepressant habits. And that time the motivation is the highest. Like how they used to tell us during our gynec posting, that you have to propose the idea of sterilization surgeries during labor to the woman, because that is the point at which the couple are maximally motivated to undergo. So at the point between 4 to 6 weeks after starting your antidepressant or anti-anxiety medication, patient is maximally motivated, also in a condition to implement that motivation. Because before that, if you say they are too depressed and anxious, they'll not be able to implement it. But at that point, they are emerging from the depression and anxiety. So when we do these two interventions, there is a very good prevention of occurrence of new onset obesity. Now, there are a lot of patients who have some weight issues and then they come into treatment for depression and anxiety. So how do you take care of this population? So we have to, first of all, look at them as a risk factor for worsening of obesity. And in that case, we particularly choose antidepressants which will not worsen obesity. For example, there are drugs like mirtazapine. So many times, mirtazapine is used for disorders of the which come with gastrointestinal conditions, irritable bowel syndrome, or respiratory conditions, it's supposed to be a very good drug. But the problem with mirtazapine is it can enhance this thing. So we don't choose those kind of drugs. We choose more of SNRIs, we choose bupropion, so that there is no further weight gain. And then this patient, of course, patients who already have obesity and then come into treatment for depression, we psychiatrists, we work a little harder to see what more is happening to them. We are more likely to find personality disorders. We are more likely to find traumatic histories. We are more likely to find multimorbidity in these patients. And for these patients, as soon as antidepressant treatment is started, within few weeks, we do refer them for psychotherapy so that these things can be taken care of. And in the next round, if they are not already with somebody who is coaching them for nutrition and diet, we'll put them in touch with the dietitian. Because the fact is that even though we are treating depression and we have very potent mood elevating and stabilizing drugs, unless these factors are taken care of, we see that after about 6 to 8 months, despite of being on medication, the depression, anxiety relapses. So being very active and aggressive with the treatment, that is how we manage. So I've made a very short presentation because most of the things were covered in the morning. And about your doubt about depression and obesity, I thought I'll cover more. This is the correlation between anxiety, depression on one side and obesity on the other. Thanks for giving me a patient hearing.
That was very crisp and very extempore. Thank you, Dr. Wani, as always.
Sir, for you, I have no question. Only request is that can you teach us how to deliver like you, the way you presented your topic, and how much you will charge for that? If you have not started doing, we will join your classes. When will you, are you going to start? Let us know, sir. That part, excellent.
See, the point is somehow sexual medicine attracts everybody.
Correct.
Somebody was asking me, why you look young? You got the point. I'm 73 years old. I told him, you just think about sex, you'll become young. You got the point. So performing is still good. There is a different aspect altogether. But the important point is, just one or two small points only. We have to catch the attention of the audience.
That is what you have done. Fantastic.
The second point, see, she did an extremely good job because she didn't bring the slides. You got the point? You were looking at it and she's so beautiful. In fact, we were all enjoying the whole this thing. You got the point?
Yeah.
But all said and done, we turn to look at the slides back or somewhere, people will get distracted. You should not. Third point, these slides, say for example, for all practical purposes, this is the first time I made use of little bit of AI and prepared those slides. I have never made use of this AI and other related things for preparing slides. Not because of anything, but because what is there in the textbook and what is actually available elsewhere, not going to interest anybody. We have to talk from our experience and maybe cases and other related things which actually sustains attention. Now information overload. In fact, even our young postgraduates, you are doing rounds and you ask the question immediately, that fellow Googles and tells you the answer in such beautiful format. No, you got the point? The world has changed so much. So nobody wants information. But only thing is, the meaning behind that information is actually what is missing and what actually we should be able to convey. Of course, how to prepare the slides, this, that and all. There is a whole lot of, in fact, we can take about 1 hour, 2 hours classes on how to prepare slides, how to write an article, how to, in fact, publish. These are all some of the things we are doing it for a long time. I would be extremely happy. But more than anything else, our current interest is actually sexual medicine. Among them, see, I am sexologist. I'll tell you this thing. I married. My wife says, I was so happy, then I married you. You got the point? That means all our problems started from the time of marriage. Deadly statement. If you really loved me, you should have married somebody else. No husband is a woman's hero. No hero is a woman's husband. No, you are getting the point. See, sometime back we were going for a walk and suddenly two dogs came barking. And suddenly I lifted my wife. She should have been very happy because I have acted like a hero in the films. No, I have done that. She told me, "You are the only man on this earth who takes the wife and gives to the dog." No. The worst possible critical comments has to come from somebody. It is wife. No, you got the point.
Right.
And you have no other alternative. You have to live with them. So that teaches you a lot of things in life.
So, madam, I think oratory skills
Yeah.
is also another topic where we need to
Yeah,
introduce
right.
in this MBM. Correct.
So, नहीं इतना नहीं दो serious topic इतना lively. It's really salute. So,
So, sir, you have another avenue to work on. How to be a very good orator where the audience is looking forward to catch the attention span of the speaker. And not
Permanent
with 20
faculty.
Happy.
here you will be.
But sir, not with 20 minutes. I think that is
You have to budget more time for sir.
okay. Any more technical questions to the
Ma'am, के
speaker?
लिए just one sentence. What you did, ma'am, many times I also think the way you presented.
हाँ.
क्या करूँ, slide लूँ, without slide करूँ, all these things. But you have managed so well. I have learned a lot from you, right, sir? Thank you so much, ma'am.
Thank you. Actually, I had made slides. I suffered a technical failure last night. My keyboard collapsed. So then I could not email the slide or bring it. So I just memorized everything and came. So I had the slides, but thank you very much.
Sir, I have a question. The post-bariatric surgery results of sexual health is still bad. We've seen that they really do not improve the sexual health of the patients even after they have lost good amount of weight. So, what's your view on that?
See, sex actually belongs to a different domain altogether. You got the point. See, bariatric surgery you are doing, maybe you are taking the certain areas and maybe anti-inflammatory, in fact, inflammatory molecules and this, that, few of the things what you are trying to do. The most important criterion here is actually the mind and the desire issues. Unless you tackle that, nothing is going to work.
Okay.
And this is one of the reasons. So, for example, as I am trying to tell a few minutes back, managing males' problems are much more easier. See, for the man, what is the important thing? He should get erection, he should have sex, and in fact, which is the, in fact, he's quite interested in understanding some of the things. No, women are stronger sex. But unfortunately, God has given all the troubles to you ladies because he thinks that you are stronger sex. See, men are rough copies. No, you got the point. He designed it properly, and that's what actually you turned out to be. No, you got it? And evolutionary wise, because a lot of ladies are here. See, if you try to look at it in lower animals, it is cloaca, both reproductive excretory functions together. It has been separated in case of females, but in case of males, everything is same. That means, evolutionary wise, you ladies are much, much ahead of we people. You got the point?
Sexually, yeah.
And say, for example, X and Y chromosome and all you have heard of. Y chromosome weakest. X chromosome can survive for 5-7 days. That's why 70% of the natural pregnancies are female. 70% of the natural abortions are female.
Males.
Male.
Males.
Somewhere around you are growing up, we initially thought that you are what you call low because you weep, you show emotions, this, that, and all. Like that is your strength. We can't show emotions. That's why we suffer from hypertension, diabetes, obesity, 100 other such things you talk about.
That's
Women live for much, much
Longer years.
longer time. All of these things are attributed to them. A lot of difficult. See, for example, there is only one small comment I'll make about her. See, in case of male, it is direct desire, arousal, orgasm, and resolution. You got the point? The Basson's model talks about female sexuality as a circular model. What it means is, it is there, but it is almost for all practical purposes dormant. Context, something actually somebody triggers. Anytime it can, in that particular circular model, it can start. Same fashion, it will ends also. So at the peak of sexual excitement also, you are worried about your child's bag is ready or not. No, you got the point. That curd is set or not. You can't enjoy. And another worst thing what I have seen about the female sexuality in our clinical practice, guilt. See, Parmal, I can close my eyes and think of about 500 girls in my life. Now you got the point? Not feeling guilty. You ask a woman to think about something sex, she thinks about husband wearing lungi, husband wearing pant, husband wearing shorts. You can't get aroused with what this particular fellow you are so bad about, you are not happy with him and you got used to. And think anything, something interesting, you feel guilty. Go to the temple, take bath. These 100 other things you try to do. You got the point? So, psychology and the social aspects are extremely important components in female sexuality. That's why. So, it is only the one particular aspect we are attending by that particular method.
So I actually want to take my topic also. See, I have gone to many CMEs with bariatric surgery, plastic surgery, and the common approach to depression and anxiety is it is because of obesity that the person has depression anxiety. It is because of some plastic surgery issue. When we treat that, this will automatically. So you have to give legitimate position to the other medical disorder as a depression or anxiety and give it independent treatment, whatever it deserves. If it is at a clinical level, you have to give it clinical treatment. If it is at a subclinical level, you have to do education, lifestyle modification. So it is my honest submission to you that if the bariatric surgeons add an arm of sexual intervention to their intervention, then the outcomes in sexual medicine will be. So you don't give intervention, how do you expect automatically it will be restored? Because as sir said, it's got a complete different etiology to itself. So just because they are co-occurring, it doesn't mean that they are serially occurring.
So again, multimorbidity with obesity is also psychogenic, and that along with whatever treatment for obesity, we have to think about treating that. Thank you so much.
Sir, I have a question for you. What is the percentage of men in your clinic who are actually appreciating the beauty of their women in their lives? Because what I see in my clinic is that the women who have a boyfriend are much better looking and they take care of themselves much more because the husband has no time. What do you think about that?
Okay, let me stand up and answer the question, okay? See, the whole point is once you marry, that's the end of the story. You got the point? No, I'll tell you. I am a married man and I can justify in so many ways this particular aspect. That the point is not that whole excitement that I have to win, I have to sustain, I have to show something. That particular aspect is taken off. Sex is an arousal mechanism wherein, see, once you are married, actually, what actually is there? This is one of the reasons why, however beautiful wife at home, that neighborhood lady is not so good looking, looks quite interesting, not because of anything. She is aroused. She is capable of arousing. And many of the women, actually, I have seen, not showing interest in many of the things man is interested. Because you have so many responsibilities. But girlfriend has no such responsibilities. You got the point. It is only the question of what we basically we talk about. The second point I'll tell you about. Say, how many of you go for lunch to home from your hospital or maybe medical college, whatever it is? Men aroused in the morning hours. Women are aroused maximal during afternoon hours.
Is it?
That's why those men who go for lunch at home, their wives look much better, happy and comfortable than. You got the point? You pack food and come and eat in the hospital. You got the point? Go home. See, eat, a little bit of pleasure and other related things actually happens. You are there working all through. And one of the worst possible time for sex is actually the night. See, I'm married to a gynecologist. We go invariably very late for many of the receptions. And this husband and wife, newly married, they are already so tired and they only remember the last people whom they have met. I'm extremely happy because by chance it clicks, my wife gets the case. And when it fails, they suddenly remember Satyanarayana Rao. You got the point? See how beautifully we have modified our whole profession. What we thought initially difficulty, now invariably we plan to go late because they remember us. No, no, you got it? The whole issue,
Sir,
why this is the what we basically call we get adopted, we get used to. There is no much challenge involved. That is one of the reasons why in the whole in couple therapy, make the individual plan in such a way that he treats his wife like a girlfriend. She treats her husband like a boyfriend. You got the point? That's what actually the whole.
I agree with you, sir, because I have a patient who could not lose weight for 10 years, and now she started losing weight, and she wears an abaya, and she shows me, she opens her abaya, and she shows me, see, I've become so thin. She lost 10 to 12 kilos of weight in about 2 to 3 months. And I asked her, what's the secret? She said, I got a boyfriend.
I'll tell you one small example. This is, you must have come across. There is a lady who came and told, my husband is having extramarital affair, but she's very happy. Why? She says, now my husband has started shaving. He's applying scent. He's doing a lot of things. Now you got the point. And then she says, she has shown him where the clitoris is. He never knew before. You got the point? See, why affairs happen is because of this. Many wives lose out on the many things. I'll tell you another one small example and then in fact, we'll talk about. We had a couple wherein husband was telling, sir, she doesn't take bath every day. She's always in the nightie and I don't get aroused. See, later we have something called as couple sessions and all that. No, the time, the wife was telling, sir, please tell him I am his wife, not his girlfriend. No, you got because I am married, in fact, they lose interest in many of the things which actually is supposed to be, which was there earlier. This is what actually should change. In fact, this is why actually, rather than just giving just one PDE5 inhibitors or maybe some medicine here, then like it is not going to work. For female sexuality, plenty of drugs have come. You talk about blemenoride and a whole lot of other things. None of those things work because primarily, predominantly, it is other related psychological to social aspects that actually matter.
So we learned arousal also has a circadian rhythm.
So, thank you, sir.
See, there are two ways to look at. Varambali is here, sitting here. Varambali is not there. No problem. No problem. See, for example, religious and spiritual, there are two different dimensions altogether. Let me first clarify. And much more of this thing is, people look into spirituality means actually they are getting away from what is called sexual. But we go with the idea that spirituality and sexuality are the two sides of the same coin. You got the point. And let me tell you, primarily, predominantly, male sexuality is related to getting aroused, mechanical, and many of those type of things actually they focus on. When you are trying to talk about couple, when you are trying to talk about women, majority of these type of things which can actually keep a person cool, happy, comfortable, they are the ones who do extremely well. See, I am married, I'll tell you, my wife, she gets upset because there is no problems at all. What is happening to the world like that? No, you got the point. There is some problem to worry about, she is very happy. When there are no problems means, she becomes so upset. This is one of the very typical female trait, what we have actually seen. You are a little more obsessional, you are a little more neat and clean, little more this, that extra compared to men in general. And say, for example, men marrying men, they are very happy. Women marrying women, they could be very happy. Man marrying a woman and woman marrying a man, the problem. You got the point? We are from totally different worlds. We are from a different planet. None of those things actually match. That's where the whole difficulty comes. How actually to sort out these two things is actually, in fact, how to adjust to this particular whole concept is all therapy is about.
Thank you very much, sir. I think
Very engaging from morning onwards. We have all been very attentive to all the sessions. There is not a single look of boredom in the audience. So thank you very much.
to introduce our next speakers.
We are continuing with our session 2, topic 3, that is obesity as a psychological disease. And I would like to call upon stage Dr. Shivram Varamballi. He is professor of psychiatry, consultant and founding head, Department of Integrative Medicine, NIMHANS, Bangalore. He is formerly consultant psychiatrist, Latrobe Regional Hospital, Australia, and his area of expertise is integrative psychiatry, schizophrenia, and uh, several mental disorders. He has numerous publications, more than 350, in in H-index journals, and he has various recognitions under his name. I would like to call upon stage Dr. Shivram.
Thank you, Nikhil. I was telling Vaishali madam that we should have given TSS Rao after lunch. She would have woken up people who are sleeping. So my topic is not as interesting as Dr. Rao's topic, but I'll try to make it interesting. Let me see if this works. Okay. Yeah. So basically, I'm going to try and focus on the link between obesity and the why are psychiatrists here to talk to endocrinologists and physicians, and why we should be looking at that. What are the mechanisms, more importantly, which are relevant to metabolic disorders in the brain, and why do we really need to look at integrative medicine for an answer instead of following what we have done till now? And I'm sure Dr. Phadke might have spoken about this, the economic survey of India. It's a very serious problem that we are facing, which is why Vaishali madam has turned her attention to this topic, that particularly in children, the number of children being obese, in fact in 2024, the world for the first time crossed a barrier in the sense that more people are overfed rather than underfed. First time it happened in the history of the world in 2024. And this is the kids, it's having a major effect on the kids. And one of the things has been pointed out is what is called ultra processed foods. And that's one major reason for the obesity crisis. And it is clearly a case of dumping, that they are being dumped on the developing countries as an aspirational thing. That this is what people in America do, कि Coca-Cola सुबह से शाम तक पीते हैं, आप भी पियो. That's the current message that is going out to the young kids. And you can see this Sting and Red Bull and all that stuff. It's completely processed food. And this is a paper which shows that there is a clear link between these UPFs and inflammation. It's not a new thing, but it has put it in a very understandable form. Government is not that it is not doing anything. They have taken some actions. There are actually, many movements, as you can see here. Poshan, Fit India movement, Khelo India, whatever. They are doing a lot of things, but that's not going to really touch most of the kids who are in school right now. Very importantly, this, I'm sure all of you have seen this article. It's not a new one. This started asking the question 13 years back. That is obesity, a brain disease, and I think we have an answer now to this question. Very interesting evidence recently looking at the link between the central amygdala and the gut and obesity. This is now a very, very clear link. I can quote any number of papers. I'm not going to go into the details of all these papers, but this is an anatomical connection between the direct correlation between the stomach and the central amygdala. So, a lot of papers are being written on this, the connection between the brain, the pancreas, and the resultant metabolic syndrome. Food addiction, weight gain, and the connection to the amygdala is another theme. A lot of papers have been published. As Vani was speaking, depression, anxiety, there is a lot of problem with the reward pathway. What does the person feel rewarded by? And if you have no other rewarding, Dr. Phadke was just telling me some time back that if nothing else in your life is rewarding, you tend to look to food to reward you. That's very simple. And particularly this interpeptide Y neurons in the amygdala are being seen to drive this hedonistic eating, not eating for, often Dr. Phadke or myself, when we speak, we say there is a difference between doing something to satisfy a physiological need, whereas doing something to satisfy something which is not physiological. So satiety is already there, but I am eating because there is nothing else that gives pleasure to me. This is called hedonistic eating. And because of all this, if we look at our current approaches, we seem to have struck a dead end in terms of not being able to make much of a difference. And primarily it is because we are not looking at the whole picture. We are looking at one side of the problem, endocrinologist is sitting and trying to see one side of the problem, psychiatrist is sitting somewhere else doing, and the same patient has to go to 3 or 4 people for the whole idea to come, and patient simply cannot afford to do that. The typical example is the metabolic syndrome, and India, because we have almost given up on GPs. Most of the Western countries, in fact, are looking now as the GP as the primary person to run the services, whereas we have gone into an area of super specialization, which is simply ridiculous, because the super specialized person really cannot cater to the whole needs of the person. We need to go back to our GPs and say being a GP is a good thing. Many of my friends who are GPs in the UK doing very well, and they control the health system, they control the referrals. When in India, a person with a slight headache goes to a neurologist or a neurosurgeon, which is very ridiculous. And metabolic syndrome is one such problem which a specialist should not be managing. And very interestingly, there is in animal research, there is a connection between this high fat kind of a diet and things like PTSD. Philosopher has recently turned his attention to health, and he asked that have we reached a turning point where we have, look at it, we taken it too far, that the mind is just a byproduct and the body is a machine. It doesn't work like that. This, of course, introduced to this group. Hopefully, all of you know the concept of allostatic load, and allostatic load is what ties all these things together. Whether it is a psychiatric problem, it's also a systemic problem, as Vani was saying, and these are the common factors. So to handle these factors, we really can't look at our own speciality through one lens. That is the problem that we have been following for a long time, and it has evidently failed in America, but we are still stuck to that model. People are going to super speciality for everything. This is something you might have heard of, a very famous brand called ASICS. It's a very famous Japanese footwear brand, and actually the expansion is Anime Sano in Corpore Sano. That's what ASICS means actually. So they are one of the best people for running shoes and things like that. And this is a very old concept from UNL. But what does it really mean? It means that all these things are interlinked. Some of our seniors, Dr. Chaturvedi, Fava before him, have shown this connection, that these are all interlinked, particularly when you look at common things like depression and anxiety. You cannot be having just a fit body or a fit mind, you need to have both. And this slide you have seen many times. I'm just putting it here to remind you that most of us deal with people who are in the orange or the red state. Nobody is really dealing with the people who are in yellow and trying to get them back to the green, or ideally the blue. That is what physicians really need to do. We should remember that the word doctor comes from docere, which means teaching. We are actually teachers. And this is a very interesting paper which show that children who are obese are already showing changes in their brain as early as 8, 9, 10, 11 years of age. You can make out changes in their brain which is predisposing them to all these syndromes at a later point of time. Interestingly, what changes this? What can you do to change this? This is a paper from India which says that BMI is important, of course, but the amount of physical activity that you do is possibly even more important for the brain. And physical activity can actually change, as Dr. T.S.S. Rao was saying, reversal of, if you lose weight, many things improve, including your sexual functioning, and physical activity is one of the important drivers of this. This is a very, I would recommend, if people have not read this paper, this is a very interesting paper, 25-year follow-up of people with pre-diabetes. This is in JAMA, very one of the best journals in medicine. And what it actually says is that over 25 years, people with pre-diabetes, most of them go on to have 2 conditions at the end of these 25 years. But the rate of having conditions is less for people who are given lifestyle than metformin. Metformin is a very good drug. I am not saying that metformin is not good, but simply metformin is not enough. It does not do enough to prevent people going into actual conditions, clinical conditions. Here the lifestyle advice, what they did was mainly physical exercise and some restriction in terms of carbohydrates and calories. That's all they have done, and they have done 25 years worth of work. It's a very, very good paper which shows that unless you take a holistic approach and look at physical exercise, diet, you are not going to get the results that you want to get. In fact, there are some people who have told me, when I see them eating a lot of sweets, they're doctors, and say, "Arey, kya hai? Ek do extra metformin le lenge, kya hai?" That's not a big issue, but it doesn't work like that, unfortunately. And this is a man who taught all of us when we were in MBBS, and he said that just because something is old, please don't reject it. New things are not always better than old things. So what do we say when we say integrative? I'm not saying that forget your medical knowledge. It's extremely important. You need to do what you need to do to get the sugar down. But at the same time, you have to look at these two aspects. You need to look at, what is it that changes? Use modern research methodology. It's fantastic, but also think of what their grandfathers were doing, what their grandmothers were doing at home, which enabled them, to be healthy. And Gita reminds us that everything has to be in moderation. Unless you control things, everything is bad. So we need to, of course, give disease-specific treatments. All of us do that. But you need to think of what will reduce the allostatic load in this person. It may be very specific. It may be sports for one person. It may be yoga for one person. It may be simple diet for one more person. Whatever it is. But you need to think of a specific allostatic load reducer. That is the point that I'm talking about. And we need to aim a little higher. We need to aim people to get into the green zone of that picture which I showed you. That's our job as physicians. It's not just to solve the symptom crisis. And you have to build resilience. This is what I wanted to stress. And for this we need to really open our brains a little more, look at what the ancients have written, and it's very clearly he says here that you cannot just treat with one system of medicine. You need to look at multiple sources. You need to become an authority of knowledge, not just your own system. Yoga is an example of this. I'm not saying yoga is the only answer. But if you look at the pillars of health, which is brought out in that human adaptome, which Dr. Phadke has released recently, yoga has beneficial effect on all these things. Yoga is possibly one of the things which can bring people back from the yellow zone to the green zone, and hopefully, if they follow it long enough, to the blue zone. The blue zone is also used, the term is used for another thing, which is, people who live longer. So there are many blue zones in the world, but Singapore is the only engineered blue zone. It's the first engineered blue zone in the world. The original ones are in Japan, Greece and all that, where people live. What has Singapore done? It has cut down on all calorie things. You go to Singapore, you cannot get any of this Sting, Red Bull, it's banned. Anything with the high sucrose level is simply banned. I don't know whether it's the right way to do it. There is no real democracy in Singapore in that sense. But they have cut down their health problems by a significant thing by making public transport mandatory. You simply cannot afford to buy a car in Singapore even if you are rich. But they give public transport right at your door. So the combination of diet, of course, their diet also is predominantly, based on their traditional recipes. So it works very well for them. And of course, yoga has it's a multifaceted action. It's not just on one system. What can we learn from the Ayurvedic thing? The most important is when we talk about personalized medicine. Now it's a big term in thing. Ayurveda is the really original personalized medicine. You are not the same as your brother, your sister, your father, your mother. Some things are common, but you are unique. You have to look at that unique prakriti and prescribe particular ahara, vihara, plus minus, herbs or whatever it is. This approach is what we need to learn from Ayurveda, not necessarily their pharmacology, because we have enough pharmacology as it is. And this is the man who actually taught us how these things work. The brain gets used to a pattern. Depression is a pattern. Anxiety is a pattern. Everything is a pattern. Overeating also is a pattern. You cannot get rid of that pattern unless you change the way that your brain interacts with other neurons. Each neuron has to interact in a different way, but we can do it. He showed us the basis for how to rewire our brains. Now we call it by a fancy term neuroplasticity. But this is the person who taught Hebb's law. All neurologists know that. And I have borrowed Dr. Fadke's slide here. A small change makes a huge thing. You get a person who says, "Arey, you look fitter than before." It changes that person's outlook permanently. So I'm going to the last section of my presentation. We have, of course, shown that yoga has produced a lot of changes in psychiatric disorders, as in the evidence at NIMHANS. But more importantly, the green part of it, we have shown how. Yoga does a lot of things that has been shown forever. But how does it do is what we are interested in, and we have been working on that. I will give 2-3 examples. This is a very, very simple study done by Dr. Kalyani, who was Dr. Gangadhar's daughter. And she showed that there is a direct effect on the limbic system, the amygdala, of simple Om chanting. It reduces blood flow to the areas in the limbic system. And as Dr. T.S.S. Rao says, most of the negative emotions come from the limbic system. Anxiety, disgust, all that come from there. And if your limbic system calms down, you think more rationally, a lot of good things can happen. Inhibition is a very, very important thing in the brain now. I don't know if any of you have read Dan Brown's latest book, The Secret of Secrets. Very interesting. Robert Langdon's latest book. I mean, he's the hero in that. It's all about neuroscience. It's in fact completely about neuroscience. I don't know how much it will appeal to general public, but for people who are interested in neuroscience, it's very nice. In that, they talk about GABA. The whole book is half of it about GABA. And they say that the inhibitory effect of the brain is, of course, it is GABA. And what happens, meditators, when they meditate, the GABA levels go up. So their disturbance, it's like a filter. What you see in the environment depends. It's like the horse, no? With that thing, it can only see the racetrack. If it sees the other horse, then its focus is gone. So GABA is what does that in our brain. And we have shown that in depression and anxiety, of course, we know it is less. After yoga, it becomes more. Not only yoga, all treatments which improve anxiety and depression increase GABA. So your ability to inhibit irrelevant things improves. And that is very, very bad in depression and anxiety. BDNF is a marker of neuroplasticity. Again, all treatments that improve depression increase neuroplasticity as shown by BDNF. Yoga is just one of those things. The single most potent inducer of neuroplasticity is electroconvulsive therapy, shock therapy. So that's very counterintuitive because you are giving a seizure to a person. But as we know, it's not what it does to the brain, it's what the brain does in response to it that is important. The brain responds in a way to increase neuroplasticity. And we have also shown that it works on the immune system. Even in patients with chronic schizophrenia, a lot of immune dysregulation becomes better with yoga. So yoga has a multifaceted action on all these things. And if we think holistically, we add yoga, you can do a lot of things. So this is a thing that we have made for depression, how depression improves with yoga. And it's a multifaceted thing, cortical modulation, cognitive, this is a EEG thing, reduction in cortisol, increase in BDNF. And this is what leads to change in the end. So what do we expect from physicians or, endocrinologists? What we really want you to think is that obesity is as much as a brain disease as a metabolic disorder. You need to be aware of other approaches and how to combine, when to combine, right? Please give metformin, please give whatever you want to give. Now, I'm not saying don't do that, but that is not enough. And you spend 2 minutes in the end extra asking about other things. What are the diet things you follow? Can you follow a certain diet? Can you do some exercise? It makes the real difference for the patient. And you have to be willing to work together with other allied health people so that you understand their point of view. And this will go a long way to help the patient. And for long term, it is mandatory that you need to consider holistic approaches, because if a person comes and says after 1 year, "Oh, I am better now, my HbA1c is back to normal, can I stop the medicine?" We will of course say no, you can't stop, but then you have to explain. Oh, you have to stop means you have to do a lot of other things. Maybe you could stop if you change your lifestyle. Maybe you do many things. If we can give that extra 2 minutes of time to each patient, I think it will make a huge difference. And so I would summarize by saying that we all can become integrative physicians. It's not very difficult. You just need to broaden your worldview a bit. It benefits the healthcare system actually in a huge way. You ask Sajid Chinoy, he will tell you. He did speak about it in the last conference that I was here 2 years back, and he said that you put one. Of course, it was in America, so he said dollars. He said you put $1 into health, you get $3 back, and he said you put $1 into mental health, you get $4 back. That's the impact it makes on the health system and the economy. But we of course need to do a lot of research, which everybody should do, not only people sitting in AIMS and demands. People like Nikhil are able to do it in a private setting. It's a very, very wonderful thing, and we all need to work together. This is eminently feasible provided you have a structure like we have created in Imans, where yoga people are there, Ayurveda people are there, naturopathy people are there, modern people are there. We all work together as one department. It's definitely possible, and this is what I believe should happen. So I hope this was useful. Thank you very much.
Thank you, sir. Now we will move on to the topic 4 of the session 2, and I would like to call on stage Dr. Alka Chadda for this session, Stigma, Shame, Blame, and Biopsychosocial Aspects of Obesity, Case Scenarios. Dr. Alka Chadda, pathologist based in Mumbai, is a doctor, author, speaker, secretary, Professional Speakers Association of India Mumbai chapter, yoga and meditation guru, founder of Hope and Care Center and the School of Happiness, Mumbai.
Where are you in your alpha, beta? So I'm going to tell you some few stories. So it's storytelling time. So you won't fall asleep. And slides are just to help you to just align with my stories. So first and foremost, what can we do to get up from our slumber? बहुत अच्छा खाना था. It was damn good खाना. Did you enjoy the खाना? Only 2 people are raising their hand. Rest of you are sleeping or what? Come in front. Let us do some activity to just move from where we are to where we want to be, A to B. So can we all just rise a little bit, move from our table? Show me your moves. Come in front. Come in front.
हेलो हेलो
Come in front.
तू फ्लोर्स पे जब है आई येलो येलो बड़ी सॉलिड मस्ती छाई हेलो हेलो तू मच है तुमने लगाई येलो येलो कंट्रोल करो मेरे भाई जग 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 के ये दिल छन छन बोले अमृत साड़ी चूड़ियां रात बड़ी है मस्तानी तो दिल भर जानी कर ले गल्ला बूढ़ियां
Thank you so much. More of my time will go, then I cannot speak more. I want to speak. It's a compulsion for speakers. They have OCD. They can't stop speaking. You agree? That's what we go through. So my topic is not a very, very pleasant topic, but still I'll try to make it as pleasant as possible. I started coming to Vaishali ma'am's place, like, I don't know, 4 years I'm coming, and this is what I remember. And this is my present to Vaishali ma'am, because the work that she's doing, the mind body complex, what she's actually initiated, and she's never given up. That is the biggest strength. So big round of applause for Vaishali ma'am. When this topic was given to me, I was thinking, what are the stories I remember? So one very sad story I'll start with, but I want to get over with it. Then I want to have happy stories. So there was my friend, she was a little overweight, maybe first standard, second standard. But her mother was also fat, but she wanted her daughter to be thin. But this child, 3 year, 4 year, 5 year, how does she understand what she should eat, what she should not eat? So her mother, I'm getting tears in my eyes right now, goosebumps. She used to strip her naked and make her walk in the colony to make her realize at the age of 5 or 6 that you're so fat. Probably she had her own problems. Probably the mother had her own childhood trauma. Psychiatrists will always tell, everybody tells the childhood trauma is what makes you do what you do. And then what she did later to come out of that obesity and her overweight problem, I'll share with you a little later. Just keep in mind this story of my dear friend. This is just an infographic view. I made it on LLM by AI, and it's about humanizing the obesity scenario. It's just about one patient came and told me he was a little overweight, and he told me that he went to some doctor, and when he presented to him, he said, "Tumhara lifestyle kaisa hai?" So he said, "I do this, 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 whatever wrong we are doing." And the doctor told him, "Abhi bhukto." How sad is that? How much we are judging each other. We're also in the same boat. We're eating now. So much I ate. I ate ice cream, then I ate meetha. Her sir told me to eat only that firni. I still ate that and ate that. So we are doing all that all the time. So we're all humans. So how she's laughing? Yeah, but that is the truth. I asked sir. Sir said only firni अच्छा है. But मैंने देखा ice cream भी है, वो भी है. So I had that anyway. So we are all humans, and I think it's high time we rise to the occasion of our overweight patients and not even call them that by that name, overweight, obesity patient. Change our attitude towards these patients and be more empathetic towards them because we are all same. We're in the same boat, and today brain is the one which is controlling the weight. The person is. It's not about his willpower. How many of you think it is willpower? It's not about motivation. It is a brain. We have seen the science today. I had made some slides, but I removed now. So I'll tell you 4 scenarios, and then I'll tell you the solution to that. So it's not a failure of willpower. This is my first patient, a 32-year-old female, Bhashwati. She came to my clinic. She was wearing a mask. Her husband was sitting in front of me. She was sitting to the right of me. She was obese, let us say. But most important thing was that she was taking 138 units of insulin. I could see only her eyes. Now, how many of you think that during the lockdown, it was a problem for us to judge the patient or to understand the patient? Do you think it was a problem? I think it was better for us because we could see the eyes. The eyes are welling up, the eyes are looking down, eyes are staring at you. Whatever the eyes are the mirrors of the soul. And I saw in this girl's eyes something. She was very quiet. She wouldn't talk at all. The husband was sitting in front of me like a big Raja Maharaja, looking at the phone sometimes, not even bothered about what she was doing. I couldn't make out from his body language what was he up to. I asked her, "Do you get time to walk?" She said, "I have a 1-year-old baby at home. Where can I go for walk?" I said, "Okay." So I asked her then, "Do you get time to go for a little bit of special food that you can make for yourself?" She said, "No." She was just nodding. I said, "Can you have someone who can help you?" She said, "I have my mother-in-law." Imagine. She has a mother-in-law, but she won't help. These are some of the problems we face in daily life. Ultimately, I had to ask her one question. How to make her move, how to change her attitude. I asked her only one question. I said, "When you were 15 years of age or 13, what are your hobbies now?" She said, "Now, no hobbies." I said, "When you were 14 and 15 and 13, what were your hobbies? What did you like to do?" She said to me, I like to paint. You can see the painting there. So without blaming the husband, without telling anything to the husband, I understood everything what was happening there. If mother-in-law is not helping, husband is also not interested in what she's talking about, I understood. I just told him, "Sir, can you just go back home, on your way back home, can you buy her a canvas and some paints?" And he said, "Yes." And he did that. And she went home, she painted. And she came back to me after 2 to 3 months. And the change in her life was that it's not about the units of insulin becoming less, it's not about the weight becoming less, but she had a bounce in her walk. She had eyes which were twinkling. She looked a happier person. What changed? Something. So I have learned one thing. I run Senior Citizens Club, and today I have joined the teenagers and senior citizens together. And what I'm learning is the seniors and the juniors, when they get together, each one becomes useful. An old person in the house is useless, right? Nobody finds him useful. The grandchildren are very busy, so they don't talk to him. But in my club, when they come, the juniors come also, the youngsters come also, and the seniors also come. And one day, the teenager's mummy, she called me. Next building only just my name is Omkar. She said, ma'am, I don't know. But this child was not listening to me at all. Now he listens to the grandparents there. He doesn't listen to his own grandparents at home. But there, they do book reading and they do all kinds of things. And he comes and he tells the stories over here and he's become a good listener. Think about it, what is changing and how you can bring it in your own life. This is Bhashwati's story. She changed. She have obviously reduced some weight also. This is a very young boy. This story is called The Story of the Disappearing Kitchen. How many people do not have kitchens in their house? Raise your hand. Nobody. Everybody has kitchens. This is the story of, yeah. So this mother comes to me. She's on her mobile. She sits down in front of me. She's working in a Reliance company, some vice president maybe. And this little boy, just 10, 11 years of boy, he's sitting overweight. Please tackle him. So look, the language. He doesn't listen to me. Every mother thinks that the child doesn't listen to. How many of you mothers here? Raise your hand. How many of you think your children don't listen to you? Nobody thinks like that. क्या बढ़िया parents हैं यहाँ पे. सबके बच्चे आपके सुनते हैं बात. I'm amazed. Anyway, a big round of applause for each one of you because your parents listen to you. You all are amazing parents. That's what I think. So, I'm just asking him, what do you eat for breakfast? It was like 10, 11 in the morning. He said, I eat upma, I eat idli, I eat this, I eat that every day. So I asked him, what did you eat today? Guess what was his answer? He said, she's still on the mobile. The mother is still on the mobile. She's not bothered what is happening between me and the baby, the child. He said, today I ate vada pav. I said, देखो 10:30 11 बज गया है vada pav मम्मी ने बनाया. He looked at me like as if I'm coming from some other planet. He said, what? Mummy? Why would she make? I said, तो कैसे बनाया? तो कैसे खाया vada pav? I think Swiggy, Zomato है ना. So this is the disappearing kitchen. She's a working woman. I don't know whether she has a husband, not has a husband. I think she was a single mother. And she was only concerned about her work, ambition, 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 tick, tick, tick. And then you bring the child here for treatment for what? Because mistake is in the kitchen. You don't have a kitchen. This is the second one. Anyway, then we helped the mother. We had to coach the mother actually. We had to counsel the mother more than the baby. And then things came in order. This is a young girl who is doing civil engineering. How many girls do you think are interested in civil engineering? No, not many, right? So I was a little surprised. She was overweight. Her mother said to me, I've kept classes for her. I've kept coach for her. The coach comes in the morning. She doesn't get up. She doesn't go. I've kept a badminton coach for her. She doesn't get up. I boil chicken for her. I give her proteins. I do so much for her, but she doesn't eat it. What do you think is happening here? Anybody? या तो तुम सुन नहीं रहे हो या तो तुम सो रहे हो. You can talk. You can always say something. So what is happening? Why is she overweight? Maybe she's depressed. But what I understood was that she's doing emotional eating. And the fact that you're right, ma'am, that she was looking down, she was not speaking, she was so frightened of her parents, and she was not opening her mouth. For some reason, I asked the father, why she's doing, when I asked her, she didn't answer the question, why civil engineering? But that time, the father told me, I make bridges. I am a bridge maker. I've got a big business. And I want my daughter to be independent. वो जिंदा रहेगी तो independent होगी ना. This is what the story is about. And this is leading to emotional eating. And here we are talking about drugs and this and that. No matter, Vaishali madam was telling, no matter how many drugs you can give to this child, but if you don't tackle her issues, her mental issues, what she's going through inside of herself, what's the idea of losing weight? This is Prahlad. He finished his engineering, electronics, and he came to me. He very proudly boasts, he sits like this on the table, and he boasts all the, this side, all the cuts on his hand. Is it suicide? Or it is attempt to suicide? Or it is showing off that I want to suicide? A person who has 8 cuts doesn't want to die. He's just attracting attention. And I got it from the first meeting. But I didn't tell him that, of course, because I wanted to be more sympathetic and more empathetic towards him. Then he told me, my girlfriend left me. I said, why? He said, because I was fat. I said, how do you know that? Can any girl tell the boy that you're fat and I'm going to leave you? No, not possible. If she really truly loves you, she's not going to care. Sir said that, his wife said that if your tummy comes out, I'm going to leave you. That's just for a joke. Nobody leaves the husband just because the tummy is coming out. Nobody is a Shah Rukh Khan here and nobody is a Aishwarya Rai here. We are all here when we accept each other, and that is how life continues. Now this boy, he's quite bad. His father and mother are doing everything for him so that he doesn't kill himself. But if he had to kill himself, he would have done something more drastic, right? I asked him in deeper moments, like I was looking at him eye to eye and asking him, what exactly is wrong with you? So when you look at the eye of a person, when you talk to them, now something changes. I was looking at his eye and I was asking him, what is the matter? What is happening here? So he started crying. And when they start crying, they cannot tell lies. How many of you agree? When you're crying, you're not able to tell lies. So such a big boy, 24, 25 years of age, is crying. He's an engineer, electronics engineer. He said the same thing to me. I want to be a writer. And he showed me so many poems that he has written. But I'm still doing this, what I'm doing. I finished my degree, but I don't feel like going to work. And that is why the obesity was there from beforehand only. But I'm trying to show the shame, the blame, the problems that we are going through, psychological problems, how the mind plays a role. And when the sir said that yoga plays a role in this, 100%. I was a lost person about 34, 40 years back. I was like, with my 2 children, I was running and running and running. Everybody knows my story. I fell down and broke my ankle. But what changed me was yoga. I joined the yoga class that time because there was one very nice teacher there, Dr. Damodaran, and she helped me to join the class. And when I joined the class, my whole attitude, my whole everything changed towards life. And I became a more giving person, a more ego-less person. I think ego, how many of you think that doctor's ego plays a big role in treatment of the patient? Yes. So I think my message to the world is about reducing the ego. And if we can be little less judgmental of the patients, that will help us in a big way. So this is an exercise I give to everybody, to my patients, to myself. The music is not there in this, unfortunately. So can we just close our eyes, sit straight? So just sit for 30 seconds, close your eyes, and just sit and think about, what do I actually want in my life? Where am I going? What do I want for my patients? Park the thoughts over there. Slowly open your eyes. What does a closed eye exercise do to you? My yoga teacher used to say, आंखें बंद करेंगे तो आपकी दृष्टि अंदर जाती है. That's the truth of life. If we close our eyes, then we look inside. Otherwise, we're only looking at outside. I want this car, I want this house, I want this. But you cannot get anything once your landscape inside is all muddled up. What I want, the clarity has to be the inside. I create the landscape inside. Then I can create the landscape, the same landscape outside. It's all about our inner journey. If we are not looking inside, that's the mind that we're not able to control them. This is my water club, and I want to tell something to Vaishali ma'am. When I see her, the way she's working, the way she's created this community, it's like a water community because we're all in it together. And here, when we come, I can tell you, so many of the doctor friends, the nutritionist friends, so many of the people who have participated, they come and they share. They share their deep secrets. Some of them have even connected with me later on. And that is a place I'm talking about, of human connection. This is a place where we can share with each other our challenges, our problems in life. And that is what I want you to think about. Next slide. This is my club actually. When I call the people together and I'm talking to them and I'm sharing and they're also sharing. So, but I want to show that water slide. I hope it is there. So when you were saying something, reading the audience, reading your wife, reading your husband, what is the meaning of reading? Reading somebody. Today I'm talking about reading the humanity, reverse of humanity. What does it mean? It means understanding and being present. I can prepare my keynote from the AI. I can prepare my blog from the AI. I can prepare any post from the AI. But it is about reading each other. What you want. I have to give you what you want. So same is with our patient. What does my patient want? My patient just wants to be seen, heard, and understood. Anything else? Maybe appreciated, maybe acknowledged. And we all want that. Do we not want all that? We all want that, right? We all want to be seen by our husband, by our children, by our sister, brother, papa, mama, everybody, friends, colleagues. We want to be seen and we want to be heard and understood. And I think that is one message that we have to just look at our patient, spend some time, what Sir said, spend some time with the patient so we can make them feel understood. I have this particular necklace. You can take a motika necklace. One day morning, 4 o'clock, I had got up and I was just playing with the necklace and I made an acronym. N is not to judge. E is empathize. C is care. K is to know the patient. L is listen. Are we listening to the patient? A is give attention, affection to the patient. What is the next place? Next is what? Let me see how attentive you are. C, connection. That connection, it has to be maintained. See, the patient is going to share. So I'll tell you what. In my consulting room, if I scrape the wall in my consulting room, I will get thousands and thousands and stories written down in my wall. I have to just scrape the wall. I'll get those stories out. Just listening to the story for the patient is therapy for them because they have not shared those secrets with anybody. That lady who's having an extramarital affair, she wants to tell me because if you release your burden to somebody else that she's having an affair, she feels better and she feels validated. She feels validated that I'm doing the right thing. I never say yes, I never say no, I just listen. And that is what I'm telling, that you have to just listen. Nothing, it's not at all an effort, not a big effort. Listening to the story sometimes teaches us something for our own self. There's a slide of water which is not there. The flowing of water. When the water is flowing, I find when I come here, it is like a water environment. Water is adaptable. Water is resilient. Water is ego-less. Water goes from higher to lower. Water is a giver, like she does. She's giving and giving and giving. And what is the most important thing is that I never see her having any ego. She's not showing off to anybody. She's doing it because she wants to do this, because she wants to pursue it. And that's why I wanted to show that slide, that how water is flowing. She's had innumerable obstacles. Not that his life has been very easy, but she stands strong and she has one very beautiful part of her strength. His name is called Chetan, and I really admire him, and I admire both of them. A big round of applause to both of them. This is my last slide. The water is flowing over the stones. So my topic is mostly rivers and rocks. The rivers are flowing over the rocks. Over a period of time, you pick up that rock and it becomes very, very soft and rounded. Why? Why does it become round and smooth and rounded? It becomes like this because over a period of time, the stone, it, as if to say the stone has surrendered its ego to the softness of the water. So can we do that? Thank you. Can we become that stone which was harsh? Maybe we had problems in our life, we were having an ego, and we still have an ego. Can we become softer so that we surrender our ego to the softness of the people around us? Thank you so much. When the artist in us is awakened, we focus on the art and we forget about the weight. I've seen it with all the patients in my life. When they start dancing, as you saw, when they start painting, singing, cooking, gardening, whatever, the weight becomes much lesser because they are focusing not on the weight, they're focusing on something more beautiful in their own life. There's a project that we can have in our life, so let's develop some good hobbies in our life and let's reduce our egos. Thank you so much.
I will call Dr. Shivram and Dr. Alka and will proceed with the felicitation. Dr. Vani also.